I have Dr. Alexander Melinyshyn. He is an FRCPC neurologist with additional subspecialty expertise in headache medicine and a member of the Canadian Headache Society and Migraine Canada Scientific Committee. Dr. Melinyshyn operates a community-based headache medicine and general neurology practice in London, Ontario. His current research interests include cannabinoid and psilocybin use in headache patients, as well as assessment of residency curricular content pertaining to headache across Canadian centres. And we also have Dr. Michael Mack. This is the first time Dr. Michael Mack has joined us for a Migraine Canada webinar, so we were very excited to introduce him. Dr. Mack is a sleep medicine specialist and staff psychiatrist at the Center for Addiction and Mental Health. He also provides cultural mental health care for the Hong Fook Mental Health Association. Dr. Mack is an assistant professor in the Department of Psychiatry at the University of Toronto and serves on the education committees of both the Canadian Psychiatric Association and American Academy of Sleep Medicine. He was inducted as a Fellow of the Canadian Psychiatric Association in 2022 and elected Clinical Vice President of the Canadian Sleep Society in 2023. In 2024, Dr. Mack was honored as a Fellow of the American Academy of Sleep Medicine. Dr. Mack is a standing member of the Royal College AFC Committee in Sleep Disorder Medicine and currently serves as the President-elect for the Canadian College of Neuropsychopharmacology. And with that, I'm going to stop sharing my screen.
Okie dokie. So we're extremely pleased, Dr. Mack and I, to introduce you to our sessions on migraine and mental health. And part one is going to look at the connections of migraine and some of the more common mental health conditions. And part two, which hopefully will be next week if everything goes well, that's going to be on functional neurologic disorders, which is a complicated and mysterious topic to both patients and clinicians alike. So we've already done some introductions. Quick disclosures, anytime we do a talk like this, we talk about what kind of other things we're involved with. I do work with the Canadian Headache Society as well as Migraine Canada, and I do a lot of research. And my projects, some of them are led by industry. So we're doing observation trials, phase 2 or 3 trials, which means we're testing new medicines. And so it's always fun to be involved with that. And oftentimes patients are looking for new and exciting options for treatment. And we take part in different advisory boards where we look at data on upcoming medications and see how best they could be used to serve our patients. For this talk, I don't think there will be significant conflicts. For Dr. Mack, I'll leave it to you.
I'm involved with some companies that make sleeping medications, and they fund our fellowship training program. And I've done some speaking for companies that manufacture sleep-related medications, but there's no overlap with our presentation today.
Perfect. So our objectives for tonight, hopefully by the time we're finished talking, you'll be better able to understand how migraines and mental health conditions like anxiety, depression, post-traumatic stress disorder are all connected. We're going to look at how mental health conditions can affect migraines and vice versa, how migraines can affect your mental well-being. And then we're going to go over scales and different ways of looking at how certain signs of anxiety and depression or PTSD might co-occur along chronic headaches and when you might want to seek some additional help. We're going to explore the connection between past stressful or traumatic experiences and how this increases your risk for developing chronic pain conditions. And this isn't necessarily limited to migraine only. And then we're going to look at ways that you might be able to help manage both your migraines and mental health challenges together. Lastly, like a recurring theme through all of this will be when it's helpful to seek care from a headache specialist or a mental health professional. So I think if you work in a headache clinic or you're involved in like Migraine Canada and you're seeing lots of people in forums and things, the stories you hear from patients can be horrifying. They have been told by some providers it's all in your head. You need to learn to deal with it. You're hysterical, an ancient term, which actually means you have a wandering uterus that comes from like Egyptian level medicine with some pretty bizarre medical ideas. You wouldn't have so much trouble if you could just learn to relax, and this is an involuntary response often. It's just a headache. Suck it up. And the myths about migraine and mental health also percolate in healthcare providers, as they're frequently taught during medical school, as part of the hidden curriculum and during your training. Sometimes you hear, oh, migraine patients are pretty difficult to deal with. I don't know how you do a headache clinic every day. Migraine patients are pretty high maintenance. They tend to call all the time and complain about side effects, and they're not well controlled. It's just a headache. It's not going to kill them. And, so that kind of comes along with things like migraine patients are complainers or it's not real neurology. And I would say that, maybe it didn't get as much attention in the past because there were things like MS or stroke or other diseases that seem more urgent, that they're more likely to kill you imminently. But I would argue instead that the disability with some of these diseases is so bad that, if you're spending 20 days out of your month in bed, you're not participating at work or in family or in things. It's a quality of life issue, and it really can affect someone's trajectory. So why is there the stigma with migraine? I think it goes back, like I know Mike and I have had lots of fun chats about weird stuff in history, but the same guy who gave us the Cartesian graph plane, which you might remember from high school drawing all your parabolas and graphs from math class, that same guy also gave us the idea of Cartesian dualism, which is that the mind and the body are distinct and separate. And, this is kind of rooted in some religious philosophy about the soul being distinct from the body. And so he thought that the mind is responsible for consciousness and self-awareness, and that, rational thought is a necessary and sufficient condition of a soul. And then in some really bizarre experiments on cats, he burned out the pineal glands in cats' brains and then found that they developed chronic insomnia and then went insane and died. And so he thought, oh, that must mean that the soul is seated in the pineal gland. And that is a pretty tenuous train of logic for a guy that gave us mathematic coordinates. And so that kind of persisted, that this idea that, maybe these disorders that we can't prove with a physical thing like a scan must somehow be a fault of the mind or probably a personal failing of your consciousness. And so some of these harmful stereotypes get perpetuated in clinical things. But I would say that with most heuristics that we have, there might be some grain of truth. Like, why are these migraine patients represented as being difficult? Is it because perhaps our medicine is not very good and so they're not having good outcomes? Maybe there are comorbid personality or mental health issues that tend to travel along with this more often than not. And providers aren't adequately trained or don't have good approaches to managing it. And that's why they feel frustrated. So I would argue that the comorbid mood and anxiety disorders make for a lot of more complexity, but it's like anything in psychiatry. If you learn the appropriate skills, you get more adept at helping to manage these conditions, and then it doesn't become such a burden. I would say that the migraine clinic, I see quite a bit of trauma, and the data we have coming out of Women's College support the idea that in a tertiary care center, a large proportion of our headache patients who are struggling with high frequency and even low are dealing with antecedent history of trauma. The comorbidity with personality disorders tends to be associated with even more severe migraine symptoms. And cluster B traits, if you familiarize yourself with some of the migraine diagnostic criteria, these are the kind of, they call it the dramatic cluster, whether it's narcissism or borderline traits, etc. But, sometimes because they're not exactly so pleasant to deal with the provider reflects back some of this attitude. And so it doesn't always make for a good therapeutic alliance. The other thing is that maybe there's some issues with maladaptive or dysfunctional coping styles, which could be part and parcel of all this problem, as we're going to see. We also have this idea of catastrophization, and I think it means something different colloquially, like in common parlance, compared to how clinicians think about it. But there do seem to be certain traits as part of mental health conditions, and maybe those with chronic pain, where things become magnified. And so they're perceived by the individual to be much more severe than an outside observer might expect. And so that becomes labeled as catastrophization. What I would argue, though, is that, a lot of patients, they get their hackles up when you start talking about this connection because they say, well, you're just telling me it's all in my head and you're blaming all my issues on mental illness. And I don't think that's fair. Having a migraine doesn't mean that all these apply to you, nor does it mean that you necessarily have a mental health condition. But what we're going to see tonight is that there's an association, that they tend to travel along with each other more often than not. And if you leave one untreated, in a kind of vicious cycle, chicken and egg kind of thing, they can feed off of each other and make it a lot harder for you to manage both conditions. So migraine is real. It's a neuroinflammatory disease. And in addition to headaches, it causes a huge constellation of symptoms. You know, we've seen in other talks with Migraine Canada, migraine is more than a headache. You have a prodrome, an aura, a postdrome, and even outside of the period where you're in pain, you may have lots of other symptoms, brain fog, neck pain, vertigo, among many others. And so these symptoms can impact daily living in profound ways. Mental health and unwellness, obviously, also is very real. And these are two very common problems. You know, our estimates in Canada are somewhere between 12 and 15% of people will experience a migraine. And so, you know, if you look at those with the percentages of mental illness, as we'll see, there's a good chance that there's going to be some overlap. So just beyond statistical overlap, like, is there more of a link between these conditions? And I would argue, like I said, these conditions tend to travel along together. So we talked about kind of the prodromal and postdromal symptoms. Anxiety is often comorbid, depression. You may have adverse childhood events, trauma, or post-traumatic stress disorder, functional bowel issues like IBS, fibromyalgia, interstitial cystitis, FND, the functional neurologic disease, which will be the subject of our next talk. All of these things, and in some individuals that are unfortunate, all these things may be comorbid. And so every person who has a headache clinic has seen some of these same stories replay over and over. It's a different person in the seat, but you're hearing the same story recounted. And this isn't exactly a new idea. Other people have written about it. You know, in some descriptions, they say major affective and anxiety disorders are shown to be the most frequent and disabling psychiatric comorbidity associated with migraine, and it can affect the way that you do in terms of your treatments. Other writers have said, well, the comorbidity is relevant in clinical practice because it may respond whether or not you respond to the typical treatments and the likelihood of you having a good outcome. And we think that perhaps, I think the most profound insight then is that there's a shared environmental or genetic risk factor with interaction at multiple levels. And we often tell our patients, well, you know, it starts in the genes. Migraine is often inherited through the family. And that kind of sets the stage. And then it could be lots of things. It could be insomnia and sleep deprivation, and then trauma, and then you have a car accident and you hit your head, or you're not eating protein in the morning or drinking enough water. All these things affect the threshold. And often, out of pragmatism, we'll tell our patients, well, focus on the things that you can change. You know, like focus on your diet and exercise and sleep hygiene. We have some medicines that we've shown can help reduce it. But for those who are looking for a truly holistic approach, I tell my patients don't neglect mental health either, because this could really be driving some of the chronic pain as well. So with that, I'm going to turn it over to Dr. Mack, who's going to talk to us a little bit about the epidemiology.
Yeah, just looking at some numbers, major depressive disorder, which is a very disabling condition, one that we see very often in psychiatric clinics, where a person is very sad or unable to enjoy things they like almost every single day for 2 weeks. It affects anywhere between 1 in 9 to 1 in 5 people in terms of your lifetime risk. Female gender is disproportionately affected, around a 2-to-1 ratio. We know that immigrants who oftentimes have to go through more adverse social events as they acclimatize to a new country and culture are also disproportionately affected. And we also see that people who have lower income suffer from more major depression compared to a similar version of themselves with higher income. And Dr. Melinyshyn has already mentioned migraines affecting a substantial proportion of people in Canada, 12 to 15%. And most people that you talk to are going to know, you're going to know somebody in your family or in your friend group that has been affected by migraine. Next slide, please. So migraines are a result of neurologic disease, and we know that what's common between mental health disorders and migraines is the brain. Both are significant brain diseases, and we see that depression is comorbid in many neurological disorders, ranging from Parkinson's disease, Alzheimer's disease, stroke, etc. And we see great overlap with migraine at about 48%. Next slide, please. So we talked about depression. What's the definition of, let's say, depression that demands treatment. And what you're looking at on your screen is the definition. So a person that has a sad mood or loss of pleasure nearly every single day for 2 weeks, and 5 of the following 9 criteria that's listed before you. Having significant changes in your appetite, typically in migraine headaches, it's a loss of appetite. Insomnia is associated with migraine headaches, and feeling very slow or being agitated at rest, having a loss of energy, feelings of excessive worthlessness or inappropriate guilt. A problem with concentration is a frequent symptom of depression. And in the most severe cases of depression, we're going to have recurrent thoughts that life isn't worth continuing. Next slide, please. So a disorder can't be a disorder unless the symptoms cause, a problem in your life. And for people with depression, it usually means a problem socially or meeting your familial obligations or doing worse at school or at work. And, we don't want to diagnose depression in people where they have another reason why they're going to feel this way. The symptoms shouldn't be caused by medication or recreational substance. Next slide, please. We like to think that the relationship between depression and migraines is bidirectional. And that's something that Dr. Melinyshyn has alluded to, that we think that a person with bad mood stands a greater chance of having migraine headaches and vice versa. And we see that the lifetime prevalence of major depressive disorder and migraine sufferers is 1 in 5 people, a substantial proportion of sufferers. Next slide, please. So how do we screen for depression? If you have an inkling that you've been having low mood, it's been pretty consistent, how might we do this in a quick and easy way? Well, one questionnaire that you might choose to use is the PHQ-9, or Patient Health Questionnaire for Depression. And it's free of charge. It's open source. And basically, it asks the symptoms of depression, and you rate it from a scale of 0 to 3, 0 being that you don't suffer from the symptoms at all, and 3 nearly every day. And as a question that ascertains if the symptoms cause you daytime dysfunction, and if you score 15 and above on this questionnaire, then you probably have a depression that demands treatment. That probably won't go away, even if we ignore it. Next slide, please. So looking more into the relationship between depression and migraine, this is taking work done by Naomi Breslaw from Michigan, who did a lot of nice epidemiologic work studying this relationship. Long story short, a person with major depression is at a much greater risk of having a first onset migraine headache within a 2-year span of study. So they took folks, next slide, please. What they did was they took over 500 people with depression, but no migraine headaches, and then more than 200 people with migraine headaches and no depression. And, they matched them up with people of similar age, background, education, income, etc. And they explored the relationship between the two conditions. So this slide demonstrates that in people who started off the study with no headache, but a history of major depression, they're at much greater risk of having migraine headaches that are new at a 2-year follow-up period. And they didn't see this relationship in people with no headache and no major depression. So what we're seeing here is that a person with major depression that has no headache is much more likely to develop migraine headaches with time. Next slide, please. And that begs the question, what about the opposite direction? What's the relationship between a person that has migraines at baseline but no depression? Will they go on to develop major depression? The answer is, for people who suffer from migraine headaches but no major depression, they're at a substantially greater risk of reporting a new onset of depression as compared to people with simply severe headaches that don't meet criteria for migraine headaches, and obviously people with no headaches at all. So we like to think that the relationship between migraines and major depression is bidirectional. One fuels the other and vice versa. Next slide, please. So they also looked at prognosis and how the symptoms of both conditions change with time. And they had some interesting findings. They found that the persistence of migraines was not higher in people with both conditions versus migraines alone, but disability was higher in the major depression plus migraine group versus migraines alone. And in people with persistent migraine, major depression was not associated with increased headache severity and disability. And the frequency of migraines did not increase with major depression. So it's a bidirectional relationship, but some prognostic features aren't modified. Next slide, please. So looking at the frequency of migraine attacks and depression, if we have a person with more migraines versus those that don't in terms of frequency, does that mean that they have more depression and anxiety? And I think, it's a great study, but I think intuitively we all know that that relationship is true, that the higher frequency of having migraines, in terms of how many times you suffer from it per month, means that you're more likely to be depressed and anxious. Next slide, please. There it goes. So this just shows you in a pictorial version of what I was saying, that higher frequency of migraine headaches leads to worsened depression and anxiety. Next slide, please. Now, transitioning to anxiety disorders and migraines. Panic disorder has the strongest association with migraine headaches. Panic disorder is an often seen anxiety disorder, and I'm going to get into more detail about what it means to have panic disorder. But very briefly, it's associated with people that get panic attacks, and they start worrying about having another panic attack, and they change their behavior in response to that. So, other associated anxiety disorders with migraines include generalized anxiety disorder and PTSD. And people with migraines are 2 to 3 times more likely to have anxiety disorders than those that don't. Next slide, please. So probably the most prevalent anxiety disorder that we see in a psychiatric clinic is generalized anxiety disorder. And we can distill the definition of it as having excessive worry over different facets of your life, whether it's at work or at home, that lasts for at least six months, more days than not, and that the anxiety leads to 3 of any of the following. Anxiety that causes you to feel on edge. Anxiety that causes you to feel more fatigued than usual, leading to problems with concentration, disturbed sleep, muscle tension, irritability. Next slide, please. And what's a quick and easy way to screen for that? Well, we have something called the GAD-7 questionnaire. And again, basically it asks you questions about how often you are liable to suffer from the symptoms of this condition, and you rate it from a scale of 0 to 3. If you score 10 and above, you probably have a generalized anxiety disorder that demands treatment. Next slide. I think that's good. Yeah. I mentioned that panic disorder is the most highly comorbid anxiety disorder with migraine headaches. And I mentioned that, it's a condition where a person starts to modify their behavior to avoid having panic attacks over the course of 6 months of suffering from this. So what's the definition of a panic attack? You have to have an abrupt surge of intense fear or discomfort from anxiety that reaches a peak within minutes. And 4 of the following. So palpitations, a pounding heart, a fast heart rate, sweating, trembling, feelings of shortness of breath, a feeling of choking, chest pain or discomfort, nausea, feeling dizzy, having a sensation of, feeling like a chill sensation, heat sensation, a numbness or tingling sensation in your extremities, feeling like life isn't real or that you're being detached from yourself, depersonalization, and a fear of losing control or going crazy or fear of dying. But you only have to have 4 more of those symptoms to understand that you're suffering from a panic attack. Next slide, please. So I've mentioned that if you have panic attacks and you start changing your behavior because of that, then you have the disorder. And a way to screen for panic disorder is with the PADIS, the Panic Disorder Screener. And again, It asks the questions of this condition, and you're rating it from a scale of either 0 to 4 to 0 to 3. Can I do a click?
There we go.
And we know that if you score positive to this, then you stand a good chance of having a condition that requires mental health professional intervention. Next slide. So post-traumatic stress disorder, and on the screen before you see 3 photos of veterans, people at war. And of course, they're at a very high risk of developing this condition. And, when people are exposed to the threat of death, sometimes that kind of stress changes your brain to the point where you suffer tremendously, both mentally and physically. We know that people with PTSD, if you measure their stress hormones, they tend to be much higher. They tend to be hyper aroused, meaning that they're on edge all the time, and it changes your nervous system. And example of this physically is when you see these pictures, these soldiers exhibit what's called the 1,000-yard stare. And we like to think that this, stereotypic face that people have when they suffer from active PTSD is a reflection of their disturbed nervous system. Next slide, please. So there's a number of criteria for post-traumatic stress disorder. Obviously, you have to be exposed to death or threatened death, or actual or threatened severe injury. And then you have to have re-experiencing symptoms. So nightmares or unwanted flashbacks. A person might develop avoidance behaviors. So let's say if a person was hit by a car and developed PTSD, they might not be able to ride a vehicle or drive a vehicle. They will start having negative changes to the way that they think, and that might be reflected by a bad mood, feeling isolated, decreased interest in things that they usually enjoy. And I mentioned hyperarousal. So, hypervigilance, having a heightened startle reaction, difficulty sleeping and concentrating. And the symptoms have to last for more than a month. Next slide, please. So we see substantial overlap between PTSD and migraines, and more so than depression and anxiety. In a tertiary, we're talking about, a specialized treatment center, outpatient clinics, anywhere between 1 and 5 to close to 1 to 3 people that attend these clinics that are headache sufferers meet criteria for PTSD. And looking at, a population of veterans, it's even higher, almost 50% of those with migraine headaches suffering from PTSD as well. Next slide, please. So what I'm just showing you is that there's been work done looking at one's odds of having PTSD versus major depression and generalized anxiety disorder in people with episodic migraines. And people with PTSD are 3 to 4-fold risk above and beyond people that don't have PTSD. And while we look at gender differences in the two conditions, we do see that in men that have episodic migraines, that they stand a much greater risk of having PTSD. Next slide, please. So another quick way, a questionnaire-based way to assess if you have PTSD is the PCL-5. Again, we're asking questions of the symptoms, and we're asking the person to rate the presence of these symptoms from a scale of 0 to 5. And if you score 31 to 33 on this checklist, then you probably would benefit from PTSD treatment. Next slide, please. So we talked a lot about problems. How do we deal with them? What's the management? The good news is that the treatments for major depression, anxiety disorders, and PTSD are very similar. In front of you, we have a list of medications that can address both conditions at once. So probably what people are using the most are SNRIs. They're a specific family of antidepressant medications that work for anxiety and PTSD. The most often used ones would be venlafaxine or Effexor and duloxetine or Cymbalta. These two antidepressant, anti-anxiety medications also have some good evidence in reducing the severity of migraine headaches. And the reason why we we suggest that these ones be tried first is because they have a good balance between effectiveness and tolerability. So a good balance between side effects and how well it works. Obviously, there's other choices, and you can see their tricyclic antidepressant medications like amitriptyline, nortriptyline, which can certainly work. It's just that they have more side effects on average. So things like sedation, weight gain, dry mouth, urinary retention, constipation. What is not recommended, though, are MAOIs, which are an older family of antidepressant medications that come with significant side effects and can be fatal in overdose. So we don't recommend MAOIs. Now, a lot of people with migraines and headaches, for that matter, take triptans to reduce their symptoms. And there's always a theoretic concern that if a person takes triptans and an antidepressant medication that increases serotonin, that it can lead to a very bad outcome called serotonin syndrome. But there's actually the evidence shows that there's low risk for this condition if you take triptans and the SSRIs or SNRIs. Next slide, please. And I've mentioned that avoid MAOIs. What about psychological therapies? Oftentimes, if given a choice, patients will prefer to avoid taking medications and go with psychological or behavioral approaches to treat their depression, their anxiety, or their PTSD. And specific to the comorbid condition of migraines and depression, cognitive behavioral therapy has been demonstrated to treat symptoms of both. And you can see the elements of this psychological therapy, which is time limited. So in this case, 12 sessions for 50 minutes each. A person will receive education about headaches and depression. You're going to learn some relaxation techniques that can decrease the symptoms of both. You're going to schedule more pleasant activities that bring you joy and reduce the ones that are, boring you, causing you unnecessary harm. Social skills training, challenging dysfunctional beliefs. So as an example, if I suffer from a migraine headache, I can't work at all and I won't be able to, get through work. Problem solving training, identifying and managing headache triggers, training in pain management and lifestyle management. So better sleep hygiene, more exercise, and then finally relapse prevention training. Next slide, please. So this cognitive behavioral therapy works well, definitely for depression symptoms as measured here, and they seemed to also improve migraine severity. Next slide. So, yeah, I'll leave here.
Great. Thanks, Mike. That was a really good overview. I think that's a good way to kind of introduce people who may not be familiar with the criteria. And we use a lot of these scales, not just routinely in psychiatry, but with most neurologists who are doing chronic pain, you'll often see many of these scales if you come for a visit. And so I just wanted to weigh in a little bit here that, sometimes for people who are reluctant to take medication, there's some opportunities there to use as few as possible. Like sometimes if you can hit two birds with one stone, kind of thing, you might get a 2 or 3 for 1 special. So for instance, Effexor, venlafaxine, can be used for major depression and generalized anxiety, but we use it off-label for migraines at very low doses. We use it for vertigo off-label. And so, it can be very helpful for those individuals, even at doses that might not traditionally be considered useful as an antidepressant. And then the tricyclics, which you already mentioned, AMI and nortriptyline, the doses that we tend to use, like 10 to 30 as a starting dose, working our way up to 50 or 75 in some individuals, those doses are pretty low. Like I think people get hung up on the idea that they don't want to start an antidepressant. But if you're really looking at the chemistry of it, it doesn't really have profound antidepressant effect until it reaches past 100 milligrams. So I would argue that, even though it's labeled as an antidepressant, that's just marketing. As doctors, we're thinking about what are the pathways that these medications are involving. As we're going to see in a second, a lot of the circuitry overlaps, and it's all the same receptors and neurotransmitters. You already mentioned CBT, Mike, but also a lot of the anti-epileptics and antibipolar type medicines that we use are also indicated for migraine. And same can be said for things like Topamax, valproate, lamotrigine, gabapentin, and its cousin. but also Botox, as we'll see. Maybe perhaps there's some evidence that Botox might help with mental health conditions. I think it's kind of fluffy science, but it's interesting. And the CGRP antagonists, this also might potentially help. And we're going to review some of the emerging data on that. So Botox for depression, like I think if you say that in most quarters, you're going to get a raised eyebrow. But there are actually a number of trials that looked at the different depression inventories and try to assess the impact in migraineurs with comorbid depression if this is actually helping them. And across a number of studies replicated, it did seem that there was a positive signal in that it was able to reduce some of their depression scores, even independent of the response to the headache. And why would that be? Like, how possibly could injecting something into your face and scalp be improving your mood? And there's an interesting hypothesis about this called the facial feedback hypothesis, dealing with proprioception, which is how your body senses its position in space. And so when you inject your forehead into the glabella and the corrugators and the frontalis, you reduce the ability to interact to emotional stimuli. All of us immediately recognize across every culture and language someone who's angry or sad or smiling. These are universal things based on internal emotions. But the relationship of facial expression and emotion is bidirectional. And there was a very interesting study that showed if you force people to smile with a pencil in their mouth a couple times in front of a mirror every day, over time they actually had improved feelings. And so there's this thinking that perhaps there's a bidirectional relationship going back to deeper brain centers. And perhaps this is how Botox exerts its effect for mental health. CGRP antagonists may also have benefit in mood disorders. And so there are a couple studies emerging. We have just more recently a new one published for fremanezumab. But this study goes back a little bit further and explores a single center that looked at all people enrolled using all different types of CGRP antibodies. In total, they got 577 patients. Majority were female, which is what we would see in a tertiary clinic, and more than 2/3 of them were chronic migraineurs. And this is also what we see because there's a bit of a referral bias when you're sent to the university. And so they followed them quarterly every 3 months and did their depression inventories. And what they found was that even if you break them down, like on average, there is significant reductions across the first 3 months in terms of their depression inventory. But even if you break them down by migraine response, so you had non-responders, partial responders, and a good responder, which is more than 50%. Even if they were non-responders, they still had improvements in their mental health. Which is kind of fascinating. And so you can't really draw firm conclusions from this study, but it's a really interesting signal that at least warrants, looking at a larger, properly conducted study to really test this hypothesis. So fascinating, like a 30% global reduction in depression score during the first quarter. So, like I said, it's found in the first 3 months, and it seems to be independent of the headache frequency. So, really promising, especially because we have a number of medications seeming to work on these pathways in development. And so, the possibilities for the future are actually quite bright. So, migraine and mental health, we know now that there's an association, but what's the actual link? And going back to our diagram here, you can see that, there are these complicated individuals in whom one or more or all of these conditions travel along together. And there are a number of different mechanisms. And the problem is there's so much complexity to this problem, even just studying it within migraine. We're looking at genetics and expression of receptors and hormones, and even how the nerves connect and form during embryogenesis when the body's forming. We look at healthy processes and disease processes. Is there inflammatory markers that are different in these individuals? Is there the idea of central sensitization, wiring in the brain that's changing in response to stimuli or even just because of disease? And then there's other theories like the allostatic changes. Your ability to respond to stress may be dysfunctional, or perhaps with repeated stimulation, you develop kind of bizarre ways of adapting to that, and that's maladaptive. We know that migraines are tied to hormones. So, for instance, many women suffer with menstrually related migraines or pure menstrual migraine. And so it's clear that some hormones play more important roles than others, like estrogen, for instance. And then we look at things like trauma and hypothalamic pituitary adrenal axis dysregulation. That's a mouthful. But basically, there's multiple levels of control over your hormones and the response that you give to stress. And this can be dysregulated in both mental illnesses and chronic pain conditions. And lastly, which is the one we're going to focus on today, is the changes in the functional connectivity of brain regions. And this is a bit of a complicated subject, but the reason I'm picking it is because out of all these levels that you could be studying, there's thousands of scientists looking at it. I think if you're just delving into this, this is the easiest to visualize in terms of how the brain is connected and why chronic pain conditions and mental health really share the same substrate and overlap. So this table I give here, not for reading or for memorization just yet, but you'll have access to this recording and the slides afterwards. And it is an interesting review article that goes over the possible mechanisms that are shared between different mental health conditions, whether it's depression, bipolar, anxiety, stress, personality disorders, addictions, eating disorders. All of these things share certain abnormalities at all the levels we just talked about. And interestingly, many of these are also described in chronic pain conditions, not just migraine. And so when we talk about the functional connectivity of the brain, to start with, like classical neuroscience, the way we used to practice classic neurology, we focused on lesions, which means something bad happened, a tumor, a stroke, you cut something out, something was damaged. And we said, well, if you cut out X, Y happens. Therefore, X must be the center of Y. So this is how the early anatomists mapped out the brain and tried to figure out what each part does. But that's a pretty simplistic way of looking at it. I mean, it's a great place to start. But the human brain actually has a lot of resilience. It has plasticity. You can take parts out and still function quite well. But the distinct regions that we just talked about are functionally connected. And that means that, even though you may not be using one part of your brain at any one time, you do use all of it, and it activates in different patterns depending on the task that you're doing. So you may have heard about fMRI, especially if you're interested in concussion or migraine research. And this is a specific type of imaging of the brain. Unlike a normal MRI, which you would get at a neurology clinic or in the hospital for normal indications, that looks at the structure of the brain. But the fMRI is watching it over time. And so it's able to look at, when the blood passes through certain areas, how much oxygen is being extracted from that blood by that area, with the thinking that, well, if it's taking more oxygen, it must be more active. And so we can try to look at the areas of the brain that are more metabolically active, which means they're involved in a certain process. So like I said, it suggests the areas that are more active, sheds light on the dynamics of how these different brain regions are connected when you're doing a certain task. So it's a very interesting type of imaging, and there's other types as well, PET scans and SPECT, which we're not going to get into today. But these are all different ways of looking at the brain and how it functions for different states. The default mode network, I would say this is the most important one if you're interested in fMRI to understand as a basis to start. And it refers to the connections between brain regions that are responsible for everyday consciousness. It's there. It's what's happening when you're not doing anything. So if you're just sitting there idling and you're just musing or thinking, that's what's happening. And so we call this kind of the default or baseline level of activity. And then the key areas associated with this default mode network are found in the cortex, and they're related to emotion and memory, as opposed to things like sensation or moving limbs and things. And it's thought to be the basis of ourselves, our ego, or your sense of self. And abnormalities in this network compared to the healthy control groups have been found in a number of different mental health conditions, ranging from anxiety to depression, PTSD, you name it. And so there's also evidence that with chronic pain, we see aberrations in the default mode network over time. So how are we going to boil that down to something plain? Like put it in simple words, Alex. So the analogy I like is that the brain is kind of like an orchestra. So each little part does something different individually, but when you power up to take on a specific task, different patterns of the brain turn off or on in concert to get things done. And then certain disease states, whether it's migraine or trauma or depression, may change the way that the neurons talk to each other. and can change the patterns in way that the parts of your brain connect to one another, whether this is at rest or during specific tasks. So even if everything looks structurally normal on an MRI, which is the classic domain of neurology, things might be functionally disordered in the way that they activate or connect with each other, or they don't activate when they should. So, there's that analogy, if you're a fan of Hannibal Lecter, they got that awful flautist that's ruining the whole Philharmonic. So, functional magnetic resonance imaging and migraine. This paper I thought was a really fascinating systematic review that came out in 2023, and basically included 224 articles. Ultimately, only 114 were included after selection because there's a lot of variability in the way that we protocol these studies, exactly how it's analyzed. And that was one of the things that they identified, was that in the future, we need to have a more concerted effort to do studies in a way that allows us to compare them and repeat them, because that's how science works. We need to replicate studies to prove that they work. And throughout all of these studies looking at migraine, there were a number of key structures that they found that were involved. And this would be the insula, the brainstem, limbic system, hypothalamus, thalamus, and the functional networks, the connectivity of it all. And so we're going to go into each one of these. What they found was that a lot of the studies that came out, people weren't able to replicate it. These were one-off studies, and a lot more work is going to be needed to replicate these findings at multiple centers to make sure we can feel confident. And so I think that's a good point to make. So we're going to start with the insula. So buckle in. We're going to do a very quick whirlwind of neuroanatomy, and we'll try to keep it simple. And if you have questions, I'm happy to answer them at the end. The insula, it regulates autonomic functions. And this is really important because dysautonomia, autonomic dysfunction, is a hallmark of migraine. And the easy way to think about this is sympathetic, parasympathetic. Sympathetic is fight and flight. What happens when you need to respond to stress. And parasympathetic is rest and digest. You're secreting things, you're breaking them down, you're digesting, you're metabolizing. And so it integrates signals that control heart rate, blood pressure, respiration, digestion. This may also be why people have all these bowel symptoms, functional bowel disorders like IBS, or the nausea and queasiness that comes along with migraine. And so it helps us in terms of bodily awareness and our responses to stress, pain, and other emotional stimuli. The insula is implicated both in migraine, other chronic pain conditions, and mental health. And in migraine, it helps to process pain perception and contributes to things like nausea and sensory sensitivity. It's involved in emotional regulation, which links it to anxiety, depression, and other mood disorders. And we can see structural and functional changes in the insula, both in chronic migraine and in psychiatric conditions. And there is some overlap in the studies. And the hyperactivity here might amplify pain perception, and then it might amplify the emotional distress. So this is when we were talking about how, these patients tend to be catastrophizers and they're always complaining. But that's not the case. It's that the whole volume knob on your nervous system is turned up, and something that should be an innocuous thing, it shouldn't hurt you at all, suddenly your scalp hurts and it hurts to touch your hair or tie your ponytail tight, or lights are too bright and smells just are revolting, and any little noise will set you off. And so it's really like your whole nervous system is keyed up, and and this is common in migraine, but we also see it in other conditions too. Just quickly looking at this meta-analysis that looked at all these studies, this is not, we're not going to go into frank deep detail, but I want to show you that when we look at the insula and its connections to other places, these are the areas that are altered compared to healthy controls. So it's clearly a nexus there, and there's lots of other regions which are implicated. The ones in red are hyperconnected, so it's like too much connectivity because of some disease state. Blue regions mean that there's less connection than we would expect for health controls. And the violet ones, these are because we have patchy evidence, and maybe it seems like there's conflicting evidence and we need more studies to clarify it. The brainstem. An integral, important part. If you're familiar with migraine physiology, we're always talking about the brainstem and the trigeminal cervical complex, the main highway for migraine-related pain. And so the brainstem plays a crucial role because it modulates pain pathways, it modulates our sensory processing. It's basically taking everything up through the spinal cord and taking it to the relay station. And so it plays a lot of important roles in how we sense our body in addition to all the cranial nerves. And so dysfunction in certain nuclei are like the little processors for each little function within the brainstem. And so areas like the periaqueductal gray or the trigeminal cervical complex, they're thought to be key bottlenecks in the migraine pathway. The brainstem also influences autonomic symptoms, lots of connections as well to insula and things like that. And so this might help explain some of the nausea, dizziness, and phono and photosensitivity we see. And when you have abnormal gatekeepers and modulation, this might help contribute to the chronification of migraine. So going from that once in a while episodic migraine to increasing frequency and ultimately ending up with a chronic headache or a daily headache. So when we look at the brainstem, again, some key areas that are clearly connected differently in people with migraine compared to healthy controls. Next is the limbic system. And this is extremely complicated. I mean, I remember studying this diagram during Royal College, and I think I tore my hair out in multiple patches. And the limbic system is fascinating. Basically, it regulates your emotions, your memory, your motivation. And so it plays a key role in certain behaviors that have always been essential to survival, like your fear response, and also your reward processing. So, it helps, people are familiar with the reward neurotransmitter dopamine. And so this is crucial. And, it can be quite disordered. And this is where you end up with things like anhedonia, where you have no pleasure. Or perhaps addictions where you're binge eating or things like this. And so dysfunction in the limbic system is linked to many different health disorders because it regulates emotion and the stress response. And when again, looking at migraineurs compared to healthy controls, limbic region is also connected in disordered ways compared to what we would see in a person not experiencing migraine. Hypothalamus. Okay, so the hypothalamus, you can think of it like your internal clock. It's deep center in the brain. And its main role is what we call homeostasis. And this is the idea that your body is always trying to maintain a constant internal environment. It doesn't like changes. And so whether you need more sugar because you're exercising, or different hormones need to be released for stress, it regulates your thirst, your hunger, your sex drive, your circadian rhythm, the day-night cycle for sleeping. There are circannual rhythms it's implicated in, which means it regulates you over the course of the year. And so it is also connected to lots of centers involved in emotional processing. And this helps to explain why we see things like insomnia and a lack of sex drive or things like this with certain mental health conditions. In migraine, though, it influences the attack onset by modulating pain pathways. It may also be responsible for triggering the prodrome or the premonitory symptoms we see like fatigue or food cravings. And then, when you have those food cravings, you go eat something salty or sugary, and then you say, well, my migraine started the day after. And then you blame it as a trigger. But in fact, it's a prodromal symptom. And there are studies that show the hypothalamus lights up in an abnormal way in migraineurs even a day or two before the actual headache attack. So, I think I would think of the hypothalamus as the true origin, perhaps, of the migraine, and then it kind of works its way down through the trigeminal complex, which is the pain highway. So in mental health disorders, it helps regulate stress response through that HPA axis we already mentioned. And it has been implicated in everything from anxiety and depression to bipolar. So, I would say that this is probably a significant nexus that would be a shared neurobiological basis for both chronic pain conditions and mental health. Again, looking at the hypothalamic conditions, we see that migraineurs have abnormal connections to these areas. It seems to be more hyperconnected than not in many of these areas. Lastly, we're going to look at the thalamus. The thalamus are like two kind of eggs that sit right on top of the midbrain as we go further higher, caudate, or cephalad rather. And so it's the main relay center. Like I think of it like everything coming up through from the spine and the spinal cord up through the brainstem, taking in all the cranial nerve feedback and everything. And that's going to be the main relay center going back and forth to the outer parts of your brain, the cortex. And it's helping to modulate everything and process it and gate it. And, it's an essential structure. And so because it's processing all the sensory information specifically, we would expect to see changes in migraine because this is a disorder of sensation. There's altered functional connectivity, and this plays a role in how we respond to things like light and sound and smells. And so this is also a key element. I just showed another little diagram there to show the complexity. There's multiple nuclei, and each of them do different things and process different things. Um, so I think, the main issue with the thalamus here is that it perhaps serves as a role to amplify and kind of feed forward migraine pain. So it's making it worse and also can cause it to persist. And it's also involved in emotional processing, and it has a lot of intimate connections with the limbic system we just talked about. So you're going to see the main theme of this is not to see if you can memorize all these different brain structures, but that they're all interconnected. They all have reciprocal connections going both ways. And it's clear that stresses in one or altered things in one area can bleed over like an equilibrium. It pushes some disordered function in the neighboring connected areas. And so maybe you start with chronic pain, and this causes changes like a domino effect that eventually leads to mental health conditions. Or maybe you start with mental health conditions, and over time, left untreated, it pushes you towards more chronic pain conditions and hypersensitivity problems. And I think that's pretty much where we're headed in our thinking, is that this is a bidirectional kind of problem. And that plays out clinically with the data Dr. Mack already showed. So again, lots of different connections there. So what are the clinical implications? I think from these studies, it's fascinating to me. I think functional MRI can contribute to how we understand migraine, and it's being used more and more as it becomes more widely available. It's not really ready for prime time. So this isn't a type of scan you can go ask your family doctor or neurologist to just order an fMRI, but it is used often in research settings. And the areas that we talked about, I think, are key players for the overlap of migraine and chronic pain would be the insula, the autonomic main center, brainstem, limbic center, hypothalamus, thalamus, and the networks that connect them. And I think what would be an interesting thing for the future is that if we discover certain patterns within the MRI activation, then we'll be able to individualize patient treatment, and maybe we can better predict which medicines you should be trying or which type of therapy you should be trying. And I think because this is so complicated, truly it is very difficult to do the calculations and compare all these studies and meta-analyze them. We need advanced data analysis, and this is an excellent opportunity for something like machine learning, which is already being employed, to isolate some of these imaging patterns, because the signals can be very hard to tease out without really refined and large-scale data analysis. So putting it together, the migraine studies show abnormal function, structure, and connectivity in certain areas that are really important for your emotional responses to pain, the emotional responses to other sensory stimuli like light, sound, smells, etc., your general mood and how you feel, and how you're perceived by others. And then these areas that have been identified, we've already talked about quite a few of them. I would say these ones, anterior cingulate, prefrontal, and cortex and hippocampus, they seem to have more activation during painful stimuli in migraineurs. While other ones like the insula and the amygdala, they have increased connectivity in resting state and stronger connections with places like the primary visual cortex or auditory, which might explain some of the light and sound. And then the amygdala, which you may know is commonly talked about as a fear center, but it has lots of different functions. So it's very fascinating. I think this is going to help us shed light on the mechanisms of migraine and generate new targets for therapy eventually. So greater pain-induced functional activation and stronger functional connectivity of these regions, this is likely contributing to the emotional aspect of the migraine. The feeling of you're just weak and awful and I can't do anything and I'm feeling completely fatigued and terrible, that might be a huge part of it. And it could partially account for the coexistence of the psychiatric disorders that we often see with migraine. One area that we want to give a quick shout out to, because it's an emerging trend in the migraine space and chronic pain space, is the idea of ACE, which is an acronym for Adverse Childhood Events. And this has gained a lot of attention because it's seen as an independent risk factor for developing mental health conditions down the road and for developing chronic pain conditions. But there's often a lot of pushback. And one of the things we hear from some skeptics is, why is this worth bringing up in the clinic? Like I'm running a migraine clinic or a busy neurology clinic. Why am I going to ask them about bad things that happened in their childhood? Like it's kind of coming out of left field. We don't have a lot of time. Like they're going to be offended or something. Is it worth bringing it up in the clinic if you're not going to do anything about it? And I would say I understand where that's coming from, but hopefully after showing you some of these data, you're going to see that it's worthwhile. And it's also a reason why we should be investing more in psychological supports for people dealing with chronic pain. Um, so starting with these adverse childhood experiences to define it, it could be anything from emotional, physical, or sexual abuse, as well as neglect, whether that's physical or emotional. And by most definitions, it has to happen before the age of 18. Some authors have been pushing to extend this window to 25 years. And they've also tried to consider adding in more expanded causes of ACE, including things like bullying and stuff. But this is harder to define. And so I think for research purposes, we have to kind of keep a narrow focus as we start out. But likely what could fall under ACE could be quite broad. And so the definition over time has been expanded to include things like household dysfunction. That could be violence from parents or witnessed or experienced themselves, substance abuse, mental illness, criminal behavior, separation from the parents, divorce. So we're starting to learn that, you know, a lot of different life junctures can sometimes have significant impact on brain connectivity and development. Those who experience ACE, it doesn't necessarily mean that they're going to develop problems down the road. It's an association, but it doesn't necessarily mean it's one-to-one that it's going to happen. But it does tend to be associated with more pain, including headache in adulthood. And there's longitudinal evidence that supports a prospective relationship with migraine. So we have a couple studies here, and I'm including them mostly for reference. I'm going to give you a little haiku just to kind of give you a teaser of what it's all about. So we have the part one looked at about 1,300 people with migraine. Majority were women, 40% migraine with aura, and a third of them were chronic. And almost 60% of respondents in this tertiary headache center reported some form of childhood maltreatment. They tended to parse it by the initial definitions of ACE. The vast majority were emotional abuse or neglect, but you can see that there were other forms too. There were 9% of people involved that actually reported experiencing all three categories, which is pretty awful. So the more types of abuse that you experience, obviously that compounds the issue. In a follow-up study, they wanted to look at how this would impact people in terms of chronification. So that means going from episodic, like the lower frequency of migraine, to going to higher frequency migraine. And so they found that the prevalence of depression was about 28%, anxiety 56%, and then specific types of abuse were significantly associated with chronic migraine and the transformed migraine, which is the old term for going from episodic to chronic. They found emotional abuse was more often associated with a continuous daily headache that's unremitting, severe headache-related disability, and migraine-associated allodynia. So that's those kind of sore scalp in the skin and just feeling kind of achy and malaise all over. Childhood emotional abuse and chronic migraine persists after adjusting also for things like SES, the socioeconomic situation. So regardless of whether you came from a wealthy or poor family or had access to other types of benefits. And so, you know, it's fascinating to see that this is an independent risk factor. Lastly, they want to look at the same cohort and say, well, what other kind of things travel along with this? Thinking back to our diagram of how it's all connected. And they found, gee, almost a third of our patients have IBS. 16% have chronic fatigue syndrome. 10% had fibromyalgia. You know, a not insignificant proportion had interstitial cystitis. A quarter have arthritis. And obviously, these are rates much higher than you would expect in the general population. So about 61% of this cohort of people at this migraine clinic had more than one comorbid pain condition. So, you know, the evidence is mounting that this is an important issue. And there are more studies now, even starting Dr. Serena Orr, who's looking at pediatric populations and following them longitudinally. More and more evidence is accruing that this is an important factor. Of course, you know, we have to try our best to try to minimize the harm that's done to people during childhood. But often that's not possible. So we need to find ways that once it's identified, how can we help them and support them so that they have the best outcomes possible? And there's promise here. I think there's a lot of hope. If we look to Women's College Hospital in Toronto, they have been designing a new program looking at a different type of psychotherapy. They call it Creating Calm. And so, There we go. And it's based on emotional awareness and expression therapy. And so they're looking at adult patients in this study, and they follow them with different satisfaction scales, and they look at all the basic migraine outcomes, like monthly headache days, etc. This poster was initially presented at our last Canadian Headache Society meeting this past fall. And we're still waiting on the final publication, but this is a little bit of a sneak peek for you. So we had about 56 participants that were contacted by the team, and eventually all the way through, we lost a few to follow up and things like that. But 21 ended up completing the full course and the headache diaries as well, and were entered in for the data analysis. So the main takeaways here is that the mean headache days of those who participated in the therapy went down significantly. So from 20.8 days when they started down to 15.5 days. And they also reported reductions in their disability scores. So, I would say if you look at the delta there, the difference between when you started and you finished, an average of 5.3 monthly headache days, it reached statistical significance. I would argue that's extremely clinically significant, especially when you compare it to a lot of our newer drugs. I think that's pretty marked and it's very impressive. And so maybe this is something we should be doing routinely. But for those of you who are listening who deal with mental health conditions, you may be aware how difficult it is to find a good therapist. So it may be a little bit easier in larger centers, but even then, it's very hard to find a good one. It's like a unicorn. And in addition to reductions in headache days and headache disability, they also saw reduction in the number of disabling headaches, the ones that were preventing them from going about their day or attending work or doing chores. So I would say that, I agree with the findings of the study. It definitely supports patients liked the program, they were satisfied with it, and it definitely should be explored further on a larger scale as a potential treatment for people dealing with migraine and ACE and other mental health disorders. So going back to that slide, we talked about all the different types of levels of why migraine and mental health conditions might share some common physiology. I think what's so fascinating is that there's hundreds of scientists, focused in, micro-focused, laser-focused on these problems and picking away at the edges of our knowledge. But it reminds me of that story of all the blind people feeling an elephant. Like one's over there touching the tail and feeling it, and the other's touching the tusk. And each of us thinks that we're describing something different, but it's really going to take a collaborative approach to sort out the whole elephant and figure out what the entire picture looks like. And so that's why I think for the future, we're going to need all hands on deck. We need primary care, we need neurology, psychiatry, psychology, neuropsychology, which is its own very fascinating specialty that spans the gaps between us all, as well as all the other allied health that help to manage these conditions. And so, neurology and psychiatry, if you want to do some fascinating reading, we are two sister specialties. We're the two sides of the same coin, and we actually began as one specialty and split apart. And I think that was probably one of the great sins, akin to the Cartesian dualism. And my prophecy for the future is that, eventually as we both pick away at the edges and describe the physiology and pathways that connect us all, you're going to see that we're going to come full circle and reunite. So in summary, I would just like to emphasize migraine, and it shares a significant comorbidity with depression, anxiety, and PTSD. The relationship is bidirectional, like Dr. Mack highlighted. Addressing for mental health comorbidities, if we ask you about it, we're not just trying to chalk up all your problems to mental health conditions. This is part of a holistic approach and really making sure that you're taking care of the whole person when you're doing pain management. And there's a lot of brief screening questionnaires that you've seen many of them today that can aid to really help you identify a problem. And you can even take these online and make an appointment with your primary care provider and say, look, I think I might be dealing with this issue. And they will know what to do. They will either, point you in the right direction, or they'll help you themselves. And a lot of the drugs that we use to treat mental health conditions and migraine often overlap. And so if you're prescribed a medication and you think, oh, this is an antidepressant, why are they giving this to me for migraine? I don't have a problem. A lot of it is marketing. There's overlap. But if you do have more than one condition, it's a great opportunity to address two issues with one solution. I would also highlight for those who are medication averse, therapy is a great option, but the gold standard is actually combining antidepressants with therapy for things like depression. But cognitive behavioral therapy is a boon. I don't think there's any person, regardless of how healthy you think you are, that wouldn't benefit from the skills that you learn from cognitive behavioral therapy. And we're starting to see programs where, at least in psychiatry for sure, they all learn this themselves, but even in medical school, we're trying to teach everybody elements of this. And we need strong partnerships, good communication between neurology and psychiatry if we're going to properly identify all these problems and get people to healthier outcomes faster. So with that, I want to thank you for all of your attention, and we're going to turn the remaining time to questions.